Thank you. Can you all hear me? The sound is good? Okay. It is my pleasure to be here. Thank you all for coming. I am really honored by this opportunity to be able to tell you a little bit about some of the work that we and others have done to try to disentangle the mess of studies that have tried to look at what diet and lifestyle factors actually have an influence on both preventing the development of colorectal cancer as well as preventing a recurrence if you already have a diagnosis of colorectal cancer. So this is the outline of my talk, and I will have time most likely for questions at the end. But I'll start with a brief introduction about colorectal cancer background, and then give you a quick crash course in epidemiology, because I think it'll help you better interpret some of the numbers and graphs that I'm going to flash across these slides. And then delve into some data about what diet and lifestyle factors seem to matter in decreasing a person's risk of developing colon cancer. And then what are the risk factors and studies that have been shown to prevent recurrence and death from cancer, and then end with some conclusions. So we all know colon cancer is a big problem in the United States. It is the third leading cause of cancer in the US in 2019, and the third leading cause of death in both men and women. And if you combine men and women, it becomes the second leading cause of death in the US. Although treatments have gotten much better over the previous decades in regards to surgery, chemo, and radiation, 5-year survival still remains dismal. With metastatic patients or stage 4 patients, less than 5% of them live for 5 years or longer. So clearly, new ways of treating and new ways of preventing this disease are urgently needed. And this is where diet and lifestyle comes into play. Because despite all of the chemo that we give, all the surgery that's being done, and all the radiation that's administered, the most common question I get when a patient enters my door is, what can I be doing? What should I be eating? Should I be exercising, and how much? And what can I take into control in my life to help put me in the best situation possible to either prevent cancer or prevent a recurrence of cancer? So the relationship between diet and cancer has been a topic of great interest for over a century. And when I recently typed in diet and cancer into our PubMed database of all published literature in the medical field, there were nearly 47,000 citations related to this topic. Out of all the cancers there are, colorectal cancer has the strongest link to diet and lifestyle. And this is supported by studies that show that there's a wide variation in the incidence of colon cancer between more developed Western countries and sub-Saharan Africa, where rates are 40 times less than that in the US. This is also supported by emigration studies, where people who move from a low incidence area to a high incidence area quickly assume the risk of the high incidence area within a single generation. And all of this implies that there are environmental influences at play. However, unfortunately, as Dr. Newman mentioned, the studies are not well done all the time, and the results are very conflicting. One day, calcium is good for you, the next day it isn't. So how do we know what to tell our patients, and as patients, how do you know what to do? So we at Harvard have been really trying to study this rigorously so that we can make evidence-based recommendations to our patients. And we are fortunate to have access to very powerful cohort studies that allow us to study these in a very rigorous fashion. So the Nurses' Health Study started in 1976 and enrolled over 120,000 healthy female nurses. They had been followed for decades. They answer questionnaires mailed to them about diet and lifestyle, as well as medications every 2 years, and the dietary part is updated every 4 years over decades. In 1989 and 1990, a substantial number of them also donated blood samples, so we can try to understand what is the biological mechanism of how these diet and lifestyle factors may be working to help protect us from colon cancer. And then the Health Professionals Follow-Up Study is a companion study in males that enrolled over 50,000 men starting in 1986, and the study followed a very similar design with a subset also providing blood samples. And so this cohort is still going on, still providing us with data more than 20 years later. And with it, we've been able to answer a lot of the questions and identify a lot of the known risk factors now that could be protective or harmful for developing colorectal cancer. The World Cancer Research Fund and the American Institute for Cancer Research put together this table after reviewing all of the literature. And I'm going to concentrate on the factors that have strong evidence behind them. you can see here that the only factor that has convincing protective evidence is physical activity. And these are the factors that increase your risk of colorectal cancer. Eating processed meat, with red meat being probable strong evidence, alcohol, body fatness or obesity, and then adult attained height is probably a surrogate for other factors that are associated with being tall. It's not actually how tall you are. There's more limited data on things like vitamin D, although I will be spending some time talking about vitamin D because that's my particular area of research interest. Now, the crash course in epidemiology. So you're going to be seeing the term relative risk or hazard ratio quite a lot in the slides. And what this means is the probability of an event, and in this talk is development of colorectal cancer, in people who are exposed to a certain dietary factor compared to those who are not exposed. So for example, a relative risk of 2.0 means double the risk of colorectal cancer in someone exposed compared to not exposed. A relative risk of 0.5 means half the risk of colorectal cancer, so that's good. And then a relative risk of 1.0 means no difference at all. Okay? Now it's important to keep in mind that relative risk is different from absolute risk. So if your baseline risk of disease is really uncommon, 1 in 1,000 only, then a relative risk of 2, a doubling of risk, doesn't really mean that much because it still means you have a 1 in 500 chance of getting colorectal cancer, and that's still only 0.2%. However, if your baseline risk of disease is pretty high already, 1 in 10, then a doubling, a relative risk of 2, means quite a bit. Now your chance of developing the outcome is 1 in 5, 20%. And then the other thing you'll see is a p-value. And if a p-value is less than 0.05, that means this is a statistically meaningful result. All right? And then finally, you're going to see a lot of these tables across the slides that I'm going to show. These are results of meta-analyses, which combine the results of each individual study that has been done looking at, in this case, it's vitamin D, and combines all of the relative risks from each of those studies into a combination risk that's indicated by a diamond at the bottom. You can see here the solid vertical line is a relative risk of 1, which means no difference, right, between high versus low vitamin D. Any relative risk that falls to the left of the solid vertical line means better, lower risk of colorectal cancer. Anything that falls to the right of that line means a higher risk of colorectal cancer, okay? And then finally, I always say this as well, all the information presented are from studies of thousands of patients, from studying large groups of people. None of them are direct recommendations to individual people, so if any of you are considering diet or lifestyle changes after this talk, please first discuss it with your physician, okay? Great, so let's get right in. So red and processed meat was one of the very first dietary and lifestyle factors to be identified as being significantly associated with a higher risk of colorectal cancer. So this is a meta-analysis that the World Cancer Research Fund did, combining all the results of these individual studies looking at the intake of red and processed meat and whether individuals had a higher risk of colorectal cancer. And as you can see here, this diamond falls to the right of the solid vertical line, and the relative risk combining all the studies is 1.12, which means a 12% increase in the risk of developing colorectal cancer with higher red meat intake. And it's 12% for every 100 grams consumed per day. And this is the portion size of 100 grams per day. It's actually not a lot. So even a little amount of red meat intake can be harmful for you in regards to the risk of developing colon cancer. Now, what are the reasons that red meat is bad? It can produce heterocyclic amines and N-nitrosyl compounds, and these are just things that have been shown to cause cancer in the laboratory, okay? And then simply another theory is just that red meat has higher fat content, and we know that higher fat content is bad for you when it comes to colorectal cancer. The next one is alcohol, and you can see here that the more alcohol you consume, the worse your risk as well. 30 grams a day is equivalent to 2 alcoholic beverages per day. Consumption of that amount of alcohol daily increases your risk of colorectal cancer by 15%. And you can see here that the more you drink, the higher the risk, so that when you're up to 4 alcoholic drinks per day, you have 60% increased risk of developing colorectal cancer during your lifetime. And here the possible mechanisms are the same. It's the substances within alcohol. The acetaldehyde has been shown to cause cancer in cells in the laboratory. Reactive oxygen species also lead to cancer. The alcohol itself may act as a solvent that allows penetration of toxins into cells that may lead to changes leading to cancer and may lead to interference with hormone metabolism and DNA repair. So in general, the guideline is less than 2 drinks per day. And then finally, physical activity is, as you recall, the only factor that has been shown to be protective against colorectal cancer. You can see that so many different groups have studied individually levels of physical activity and how they relate to whether or not colon cancer develops. And you can see that the combined relative risk at the bottom is to the left of that vertical line, so it's 0.80, which is a 20% decrease in colorectal cancer with more exercise. And in general, what is the amount of exercise that has been associated with benefit? It's about 30 minutes a day of brisk walking for at least 5 days a week. So it actually isn't a lot. And the 30 minutes doesn't have to be all at once. It can actually be spread out throughout the day. And what are the mechanisms here? Well, obviously, if you exercise more, you reduce body fatness and obesity. And we know that obesity, we'll get to on the next slide, is a risk factor for colon cancer. Insulin signaling. The insulin pathway has been shown to be growth promoting in the laboratory in regards to cancer. So the less insulin, the better, and exercise does decrease the amount of insulin resistance in the body. It also reduces the inflammatory state in the body, and we know very well that inflammation leads to cancer. And when you exercise, your digestive tract is stimulated, right? Things move through more quickly so that any toxins that could be in your diet that you ingest have less contact time with the lining of the colon where cancers first develop. So if there's less contact time, perhaps there's less exposure to potential carcinogens. And then finally, body mass index. You can see how many studies have been done looking at obesity and whether that relates to colorectal cancer. And at the bottom here, the relative risk combining all these studies is 1.05. So there's a 5% increase in the risk of developing colorectal cancer with every 5 kilogram per meter square increase in body mass index, which is what we use to define obesity. You can see here that there is a dose-response relationship. So a BMI of over 25 is the definition of being overweight. And if you're overweight, there's an 8% increased chance of developing colon cancer. Obesity is defined as a BMI over 30. If you have a BMI over 30, the risk goes all the way up to 34% higher risk. And the mechanisms here, again, really similar to what we think of with exercise. Obesity increases insulin levels. Obese people have higher levels of insulin resistance, and they have higher levels of inflammation in the body. So all of these factors have been studied in isolation, but what is the impact if you combine all of these healthy behaviors and someone actually follows all of these recommended diet and lifestyle behaviors? So we looked at this. We looked at whether in people who had a normal body mass index, exercised a lot, took a multivitamin because folate is also thought to be protective in some studies, consumed only moderate amounts of alcohol, did not smoke, and ate minimal red meat. We looked at how many men in the health professionals follow-up study actually followed all of these diet and lifestyle recommendations. And it turned out of 48,000 men, only 3% actually followed all of these faithfully over years. But in those 3% of men, their risk of colorectal cancer was 71% lower. So clearly, diet and lifestyle are extremely important. So in addition to colon cancer screening, this can help significantly reduce your risk as well. Now, I want to spend some time on vitamin D because it has been shown as well in the laboratory to have anti-cancer properties. It can inhibit tumor growth, both in cell lines as well as in mouse models of colorectal cancer. It can decrease inflammation, and we know that it modulates immunity so that the immunologic environment may be more favorable and protective against cancer. In a meta-analysis here of 9 individual studies that looked at blood levels of vitamin D and risk of colon cancer, you can see that individuals with the highest levels had a 33% lower risk of developing colorectal cancer if they have a higher level of vitamin D. Now, all of these studies that I've shown you are only epidemiologic observational studies. They only show associations, and they don't necessarily conclude cause and effect. And the only way to really figure out whether vitamin D causes colon cancer is to follow all of this up with a randomized clinical trial. So that's what my colleagues at Brigham and Women's Hospital did. They conducted a very large study called VITAL and enrolled over 25,000 healthy individuals across the United States. They randomly assigned them to take either 2,000 units a day of vitamin D or placebo. And then there was a secondary randomization as well to omega-3 fatty acid or placebo. And then they followed them. I think the average duration of supplementation was around 5 years for how many of them developed cardiovascular disease and cancer. And actually, the data were negative for vitamin D. So despite those strong observational studies that showed a link, the randomized trial did not. So 2,000 units of vitamin D did not significantly decrease the risk of developing any cancer of any type compared to placebo. And in colorectal cancer, it did not affect the incidence of colorectal cancer either. However, interestingly, they did find a possible benefit of death from cancer. So again, vitamin D has these anti-cancer properties, so once you have cancer, perhaps there's a role for vitamin D. And this led us to wonder, all of these diet and lifestyle factors are useful for preventing colon cancer in healthy people, but do they also have a role once you're already diagnosed with colon cancer? Can it help prevent a recurrence or death from cancer? So we don't have a nurses' health study or health professionals' follow-up study to study secondary prevention, but we do have these clinical trial cohorts of thousands of colon cancer patients who enrolled in this clinical trial of postoperative chemotherapy. They either got a triplet or a doublet, and ultimately, both of them resulted in the same outcome. So we combined all of these patients into one large cohort and followed them over time. We gave them the same diet and lifestyle questionnaires that were administered in a nurses' health study and health professionals' follow-up study. And patients completed the first one 2 months into chemotherapy after they've had surgery for removal of a stage 3 colon cancer. And then they completed a second questionnaire asking the same diet and lifestyle questions 6 months after completing chemotherapy. Because as you can imagine, your habits may change while you're on treatment compared to when you're done with treatment. And so we were able to look at all of these various factors and more. So what did we find? Physical activity still seems to be protective after a diagnosis of colon cancer, where subjects who were walking for at least 6 hours per week had a 49% decrease in their risk of having a cancer recurrence or dying from their colon cancer. And this was statistically significant with this p-value less than 0.05. Now, again, that was just an observational study. So every time we get a chance to, we try and follow up with a randomized clinical trial to really prove cause and effect. Does exercise really decrease your risk of having a recurrence of your colon cancer? So this study has been going on for quite a long time and is still not done yet. As you can imagine, these studies are quite hard to do, randomizing someone to exercise or no exercise, but they're continuing with it. And so they enrolled high-risk stage 2 or stage 3 colon cancer patients who got surgery and also completed postoperative chemotherapy. The control arm just received general health education materials, whereas the interventional arm received the general health education materials along with a very intense monitored physical activity program. And so the goal is to see whether administering this exercise prescription can really help decrease your risk of suffering a recurrence. So we eagerly look forward to that data. And then the other thing we've been studying is dietary patterns. So although there are a lot of studies on individual components of the diet, actually studying the whole dietary pattern may better reflect the real-world complexities of your diet, because it accounts for interactions and synergy among the different things that you eat. They're all interacting with each other in your body. And we've been able to identify 2 major dietary patterns. So the Western pattern diet is the McDonald's diet. It's red meat and processed meat, refined grains, lots of sweets and sugars, fried foods, and high-fat foods. Whereas a prudent pattern diet is more of a Mediterranean-style diet, high in vegetables and fruit, legumes, whole grains, and healthy proteins. And these 2 dietary patterns have been studied for risk of colon cancer, but as well as risk of heart disease, diabetes, and a variety of other chronic health conditions, and found to be very important. So when we looked at our cohort of stage 3 colon cancer patients, you can see how dramatic this effect is. Somebody who consumes much more of a Western pattern McDonald's diet had almost quadruple the risk of suffering a colon cancer recurrence or dying from their colon cancer than someone who consumed very low levels of a Western pattern diet. We then looked at specific components of that Western pattern diet, including ones that result in a high insulin load or high glycemic load. And what this means is consumption of a diet that produces an insulin spike in your body. if you remember, insulin seems to be bad for cancer. In the laboratory, insulin promotes cancer growth. We want as little insulin in our body as possible. So this study showed that if you consume a high amount of foods that lead to an insulin spike, and these are mainly carbohydrates, sugars, and sweets, then you have almost triple the rate of a colon cancer recurrence or dying from your colon cancer. Similarly, we looked at glycemic load, which is how much of what you eat results in a sugar spike in your body. And here, similarly, you have almost double the risk of a colon cancer recurrence if you are eating a diet that results in high sugars in your body. And so again, these are studies in isolation. What about a combination of healthy behaviors? What impact does that have on your risk of suffering a colon cancer recurrence or dying from your cancer? So although many of these have not been studied in a randomized clinical trial, which is the highest level of evidence, you can imagine it's hard to randomize someone to a healthy diet versus a not healthy diet. All of these things are good for you for a variety of other reasons. So the American Cancer Society actually put out these nutrition and physical activity guidelines for cancer survivors. And they recommend that you maintain a normal weight, exercise at least 150 minutes per week, and this is just brisk walking, limit red meat intake, eat plenty of fruits and vegetables, and choose whole grains instead of refined grains. So we were curious about how many colon cancer patients actually follow all of this and how compliant they were and whether that was related to their risk of colon cancer recurrence. So we developed a scoring system where 0 is poor compliance with these factors and 6 is the best compliance or perfect compliance. And what we found was that subjects with the highest compliance, 5 to 6 score, with the ACS guidelines had a 31% decrease in the risk of having a colon cancer recurrence or dying from the colon cancer. And then again, I just wanted to talk about vitamin D again, given that interesting result from the VITAL randomized trial. Given that result that perhaps vitamin D may have a beneficial impact on people who already have colon cancer, we took a look at this in 300 patients in the Nurses' Health Study and the Health Professionals Follow-Up Study who had colon cancer stages 1, 2, 3, and 4. And what we found was that for patients who had higher levels of vitamin D in the blood, above a level of 33 nanograms per mil, there was a 48% improvement in their survival from colorectal cancer if they had higher levels of vitamin D compared to very low levels of vitamin D. And this was statistically significant. We also found that the benefits seemed to be better in more advanced stages of disease, so patients who had stage 3 or 4 disease. So we took another clinical trial cohort of all stage 4 colon cancer patients, so these are metastatic, for the most part incurable colorectal cancer patients who had not been treated with chemotherapy yet, and we found a very high rate of vitamin D deficiency. So vitamin D deficiency is defined as a 25 hydroxy vitamin D level less than 20, and the average level prior to starting chemotherapy was only 17. So more than half of metastatic colon cancer patients have vitamin D deficiency, which is a problem if we think that higher levels of vitamin D are protective. And what we found was that if for some reason you do have higher levels of vitamin D in the blood prior to starting your chemotherapy, your survival is much better. And this is the difference. People in the highest quintile of blood levels of vitamin D had an almost 33-month average survival compared to those in the bottom level who had only a 24.5-month survival. This difference is larger than any difference that you would see with a chemotherapy agent. So vitamin D may be doing something important here in colorectal cancer. We also found that higher levels of vitamin D are associated with the delay and progression of your cancer from treatment. So there was a delay and control of the cancer for an average of 12.2 months for those who had the highest levels of vitamin D and only 10 months for those in the bottom levels of vitamin D. And this was again statistically significant. So these are all observational again. They only show associations. And so we recently conducted a clinical trial to try and see if we can prove cause and effect. Does higher levels of vitamin D result in a better survival for colorectal cancer patients? And this was just recently published earlier this month in JAMA, where we enrolled 139 previously untreated metastatic colorectal cancer patients. They all received standard chemotherapy with FOLFOX and bevacizumab. And then they were randomly assigned to receive very high doses of vitamin D, so 8,000 units per day for 2 weeks, followed by 4,000 units per day for the entire time that they're on the study. Patients in the control arm who were assigned to the control arm received only 400 units per day, which is the amount found in the multivitamin. And the primary endpoint was whether or not we can delay progression or death from colorectal cancer. And what we found was that indeed, patients randomized to receive high-dose vitamin D had significantly longer control of their cancer than those who were randomized to the low dose. 13 months on average of disease control on the very first treatment that they started for their colorectal cancer, compared to only 11 months for those in the low-dose vitamin D arm. And so that was a small study of only 139 patients, and we're now conducting a larger confirmatory phase 3 trial to really prove that this may be part of a patient's treatment recommendation. So this will be done in conjunction with the National Cancer Institute. The trial is called Solaris and will randomize a much larger number of patients from about 800 different sites across the country, so we get some geographic diversity. So 400 patients randomized again to standard chemo with either high dose or low dose vitamin D. And so the study will be opening later this year. So again, I've gone through a lot of data. How do we actually advise our patients, given that we don't have randomized clinical trials for a lot of these things? This is what I generally tell my patients. So again, to review, to decrease the risk of developing colon cancer, maintain a normal body weight, exercise as much as you can, do not drink more than one glass of an alcoholic beverage for women and 2 for men per day, no smoking, and minimize red meat. I had aspirin here, although the data around aspirin has been more confusing lately, and there are side effects associated with aspirin, so we don't necessarily recommend aspirin for everybody anymore. In terms of improving your survival and decreasing recurrence, you can see it's a lot of the same things. So normal body weight is still important, exercising is still important, and then more about the diet here, trying to avoid a high glycemic and insulin load diet. And this usually it resembles a more Mediterranean style diet, and avoiding this McDonald's Western pattern diet. And then maintaining vitamin D levels in the sufficient range, which is generally above 30 nanograms per mil. Again, the data are still preliminary, but this is good for your bone health anyways. Okay. So I just wanted to end really quickly by describing another phenomenon that we have been noticing as a public health problem, which is the rising burden of young people getting colorectal cancer. And the reason that this is relevant is that we do think it's due to diet and lifestyle factors that are affecting this younger generation. And so we've noticed that although colon cancer has been steadily decreasing in men and women who are over the year of age of 50, this is largely due to institution of colonoscopies and colon cancer screening and efforts on the part of primary care physicians to really ensure compliance with colon cancer screening recommendations. You can see that the rates of colon cancer are going up in patients ages 20 to 49 ever since the 1980s. Most of these patients are young and healthy. They're not obese, they exercise, they follow a healthy diet, and they don't have a genetic syndrome or a family history, yet they're being diagnosed with colorectal cancer unexpectedly. The other concerning factor is that these patients are getting diagnosed with very advanced stages of disease. So 41% waited over 6 months before seeking medical attention for their symptoms because colon cancer is not on their radar as a 20 or 30-year-old. Colon cancer is also not on the radar of primary care physicians or urgent care doctors or emergency room doctors who dismiss symptoms a lot of times based on a patient's age, that it could not be due to colon cancer. So 67% in this survey of young onset colon cancer patients saw 2 or more physicians prior to being diagnosed correctly with colon cancer. And this resulted in 71% being diagnosed with stages 3 and 4 disease, which are much less curable than stages 1 or 2 disease. This led the American Cancer Society to recommend lowering the age at which colon cancer screening should start from age 50 to 45. We're clearly not catching all young people who are getting diagnosed with colon cancer, but this is a good first step. And then while it's hard to get a diagnosis of cancer no matter how old you are, it is particularly hard for young individuals, where 80% have children under the age of 18 when they're diagnosed. Many want to start a family, but 64% did not have fertility counseling before starting chemotherapy and radiation. 64% had to take a leave of absence from work or school, and this resulted in financial difficulties. So in order to try and address this, the Dana-Farber has started one of the first young onset colorectal cancer centers dedicated to helping this group of people and figuring out why this is happening in regards to diet and lifestyle. So our mission is to provide good clinical care, expert and compassionate and cutting-edge care to patients with young onset colorectal cancer, conduct research to understand why this is happening and what are the underlying reasons so that we can try and prevent this, and increase education and awareness so that we can improve in prevention and early detection. So at our center, patients get a multidisciplinary evaluation and an upfront genetics appointment. Everyone gets personalized treatment. So every tumor is sequenced, we understand the molecular profile, and the results are reviewed by a molecular tumor board. And a personalized treatment report that could include a clinical trial recommendation is returned to the oncologist. Patients also get a dedicated program coordinator to help them navigate the often complex healthcare system, and a dedicated social work for additional support. We're also starting a new research study of young onset colon cancer patients called the Beyond CRC Project, which stands for Better Understanding of Young Onset Colorectal Cancer. And another reason that we chose this name, Beyond CRC, is that there are many ways to get beyond and live beyond a diagnosis of colorectal cancer. You can complete treatment and get beyond it that way. You can learn how to live with cancer and treatment as a survivor. Supportive care for the whole patient, not just medical care, but psychosocial care, nutrition, integrative therapies, and not just for the patient, but for the whole family. And then helping those who come after through research. So our study will include a very comprehensive database of clinical, treatment, and survival data, tumor, blood, and stool samples, because we think microbiome, which is also affected by diet and lifestyle, may be implicated, and the same diet and lifestyle questionnaires that were administered to the Nurses' Health Study and Health Professionals Follow-Up Study. And we want to study all these different aspects of the patient's cancers to really try and understand what is going on. And then finally, we want to raise public awareness and education by holding seminars and having newsletters for patients, partnering with foundations and advocates, and then also educating the community at large, as well as doing some advocacy at the national level as well with the National Cancer Institute and the government. So we are launched as of March 2019, and this is our website, and this is our email if you have questions or want to refer patients. That's it. Thank you for your time.
Thank you very much. That was wonderful. So, Timmy, I can ask you a question maybe before anybody else does. I think as oncologists, when people ask us, how did I get this, we always will say, well, there are genetic changes in your cancer. And I think you know we can actually take the cancer, send it to our favorite institution in Boston named Foundation One. We get a panel of 350 genes that are tested. It comes back and it says you have mutations in 1, 2, 3, 4, 5, up to maybe 10 or 15 of these genes are mutated. You're suggesting that dietary changes are preventative. How is it that lifestyle changes are going to affect the genetics of your cancer?
That is a great question. I don't know that we know the answer to that, but we do know that a state of obesity, for instance, or sedentary behavior, somebody who's not exercising, can increase levels of inflammation in the body, which can then change the immune cells that are in your body, and perhaps there's less protection against developing colon cancer or preventing a progression of colon cancer because of this. And obesity and sedentary behavior and levels of inflammation also change the microbiome, which is the community of trillions of microorganisms that are living in our colon right now that affect whether or not cancer develops and how it responds to treatment. So those are some of our leading theories. We do know that certain components in the diet and insulin can also lead to changes in gene expression. So the genes that are turned on or turned off uncontrollably may be affected by what we're actually consuming in our diet.
As you're talking, and Dr. Newman mentioned that most people think that cancer is genetic or driven by genetic mutations. And the data you're providing seems like there may be a metabolic component in which the microenvironment is equally as important, and perhaps even more so in the prevention of recurrence, because we know that even at the time of diagnosis, there are stem cells throughout our body that are potentially cancer cells. So we never lose the risk of having cancer.
That's right, and those stem cells are implicated in why a treatment stops working, why resistance develops. And so if we know what diet and lifestyle behaviors affect those cancer stem cells, we can potentially increase our survival. I want to point out that only about 10% or less of colon cancer is genetic, meaning through something hereditary that's been passed down through the generations. So most of it is probably a combination of genetics and environmental influences, but most is sporadic and probably influenced by the environment and what we're eating and doing.
Can cancer drivers be changed through these interventions because of perhaps if you change the metabolism, the way the metabolism works in your body, can you turn it off? Can you change the cancer drivers?
We don't have evidence of that yet. Those studies are hard to do, but we don't have evidence that you can actually, if you have a KRAS mutation in your tumor, I don't know that that will go away, depending on whether or not how much you exercise, for instance. We do know that we're basing our treatment decisions on these genetic results that we get back from Foundation 1 testing. We actually think that certain diet and lifestyle factors may be more effective depending on your molecular profile as well, because all of these things interact, and it's just so complex to all the signaling that happens to lead to cancer. So we're soon going to be doing personalized treatment, or I think we're going to get to the era of personalized treatment and personalized prevention. If you have a certain molecular profile in your tumor, you might be more susceptible to the benefits of exercise, for instance. We don't know that. We're not there yet, but I think that's where it's headed.
The microbiome of the gut. Within the framework of what you're discussing, can you discuss a little bit of that?
Yeah, so the microbiome, for those who are not familiar, again, we have trillions of microorganisms living in our body, and the majority are living in our colon. And we have done studies that show that depending on what mixture and community of bugs, bacteria are in your colon, can predispose somebody to developing colon cancer and also affect how well they respond to treatment. One in particular for colon cancer is Fusobacterium nucleatum. And we've shown that about 30% of colorectal tumors seem to have the presence of this bacteria that has been associated with shorter survival and a worse outcome. We've even shown that if you give an antibiotic that targets and tries to kill that bacteria, you can slow the growth of colon cancer. So there are definitely influences from the bacteria that are right around where that tumor is forming that are affecting how we respond to treatment. There are a couple of published papers that immunotherapy, which are these new drugs that unmask the tumor from your immune system, they don't work for the majority of colon cancer, but for lung cancer and melanoma, certain bugs in your gut affect how well you respond to those treatments. So we're only beginning to scratch the surface of what all of these bacteria are doing in our body. What metabolites are they producing? How are they breaking down the foods that we're eating? And all of that might be playing a role in why we develop colon cancer as well as how long we live.
Hi, I was wondering, so kind of following up what you're saying, just taking probiotics, and there's like a lot of different kinds of bacteria that you can take,
Right.
Does that affect, or has anyone started looking at that? I assume that's going to be
People have looked at it, and it doesn't seem like probiotics are helpful. They only are composed of a certain number of and specific types of bacteria. We don't even know yet which ones are beneficial, and we have evidence that it's more how diverse the community of bacteria are in your body. If you're not all predominantly Fusobacterium, that's probably good. It's more the diversity, and we don't know yet, but probiotics are not enough.
Hi, have you done any studies on stress and how it relates to hormones or meditation to try and control it, or are there any studies on stress related to cancer?
I think that's a great question. I am not aware of any. Again, I think part of the problem is that these studies are really hard to do, and how do you objectively measure stress? We do know that stress increases the amount of cytokines in the body, it increases the inflammatory state, and so one can surmise that perhaps that does play a role, but I don't think we know yet.
Timmy, we were talking a little bit about the lifestyle and other cancers, and you mentioned that breast cancer was one where lifestyle seems to have a sizable intervention. I think endometrial cancer is also one that is very, very tightly related with obesity. Do we see the same impact of lifestyle in other cancers? And there's a second question that I'm going to insert in there as well, and that is, do you think the shortcoming is with data? Is it because we don't have enough data, or we don't have the capacity to assimilate all the data? And is this a question of Watson gathering up these innumerable data points, types of bacteria, exposure to antibiotics, diet? Obviously, too many factors to run a randomized clinical trial. Is this a Watson question, or is this the data is just not available?
So it might be a little bit of all of the above. So the data is strongest for colon cancer in regards to diet and lifestyle having an effect. And as you said, breast cancer, it also seems to play a very important role in breast cancer. I think one of the reasons we say this, though, is because breast cancer is one of the most common cancers in women, and colon cancer, as you know, is the third leading cause of cancer in the US. So there are a lot of patients to study, and there are scientists interested in diet and lifestyle and in studying that in these patients. I think that our data is not good because it's really hard to do these studies. These Nurses' Health Study and Health Professionals Follow-Up Study and questionnaires are all based on recall, right? What do you remember from the past 3 months about what you ate and how much of it you ate? We've validated those questionnaires because then we cross-check them with food diaries, and we measure levels of metabolites in the blood, and so they are validated, but it's still an imperfect measurement. Whereas, if you're measuring the effect of how well a chemotherapy works, it's much easier to determine if that is effective or not, and whether someone is taking the treatment or not. So there's difficulty in measuring, there's difficulty in proving cause and effect. It's really hard to do these clinical trials. One, it's hard to randomize to a diet and lifestyle factor, and two, funding is also not available. So to your point, a lot of this work has been done with philanthropy because it is very difficult to conduct clinical trials like this when there's no drug company who's eager to make some money off of their product. So these studies are extremely hard to do. So for example, with our struggle to do the vitamin D trial, there was no industry sponsor who was interested in funding that study because the supplement makers are already very profitable because people take these supplements without the data. And they don't have infrastructure. They have not traditionally been involved in conducting rigorous clinical trial research studies. So there was no funding available there. We had to piece it together from the NCI and philanthropy. And then there's similar struggles with the phase 3 trial that's about to happen later this year. We're still trying to come up with funding to do that. There is no interested industry sponsor who wants to pay for the conduct of these very large and very expensive studies. And I agree with you, if vitamin D ended up being protective, it's cheap, it's safe, it's accessible anywhere regardless of a country's resources or a person's socioeconomic status, it could have a global impact. But there isn't funding to do the work.
I had a question about the young onset patients. Are there any trends of comorbidity that you see in those patients?
So almost none of them have comorbidities. They're all very healthy, very robust. They have no other medical issues, and they get diagnosed with colon cancer out of the blue. As a result, they're very healthy, and so they end up getting a lot of treatment. They get the most aggressive chemo, they get surgery more often than older patients, they get radiation more often, yet their survival is not incrementally better. And so this leads us to believe that these cancers that happen in young people are probably biologically different and maybe more aggressive.
Is the microbiome the same in young and older?
So that's one of our research questions. I think it's different because they're consuming a very different diet, and there's more obesity and there's more sedentary behavior. All of that affects the microbiome. So that's one of our leading hypotheses.
Do any of the risk and benefit factors on your colon cancer research also play out for pancreatic? That's number one. Number two, obviously in Africa, the vitamin D that they're getting with the low incidence is not from vitamin pills. When you're doing your research, are you extracting vitamin D for the patients from the healthy Mediterranean diet or from pills? And then finally, in terms of your own work in the last year, what's the single most interesting outcome that you've seen, or surprising outcome?
Right. So, So the vitamin D, the lower incidence of colon cancer in Africa is because they're out in the sun all day, and they're very physically active. They're not sitting around, and so that probably is a major underlying reason. And their diet is completely different as well. Many fewer processed foods and things. So it's all plant-based and natural. So I do think that that plays a role. And in our study, we can't advocate for being out in the sun because it leads to skin cancer. And so the most effective way to raise your vitamin D levels is through taking supplements. And in regards to the most interesting thing that I've been doing recently, it really has to be the microbiome. I mean, it's just a whole nother world in there that we don't know anything about, and is probably playing a huge part in everything from obesity to heart disease to autoimmune disease to cancer. So that is the most exciting thing that's been emerging lately.
Very good. One more question.
This is a comment more than a question, but I would love to hear you speak to this. It would be wonderful to blame my diagnosis on some horrible gene I inherited from my great-grandparents, and I could say I have bad luck. But I've sat here the last hour feeling guilty that I'm fat. I have sat at a desk for the last 35 years. I've gone to McDonald's too many times. There must be other people sitting here thinking I did all the wrong things for the last 30 years.
And so that wasn't my intention at all, because I think I tried to emphasize that these are associations, right? We don't actually know the true underlying factor. There's no randomized trial that says obesity causes colon cancer or this diet causes colon cancer. People who follow a certain pattern, they may have some other underlying factor that is the true underlying reason why the colon cancer happens. So, and then there are plenty of people, like these young people, who are not obese and follow a healthy diet, and this still happens. So it is not just the diet and lifestyle, but what we can say is that we can partially control what happens to the cancer and how it responds by trying to follow these healthy behaviors.
On September 14th, our next community lecture will take place, and Sherry Clampett is going to be speaking on stress and cancer. September 14th. Take out your iPhones now, turn them on, and September 14th. I hope you'll be there.